Okay, let's get started. Good morning, everyone. Welcome to Computing MTU Showcase. This is a session for health information and infrastructure, financial technical systems, and modeling. This is Xin, the Assistant Professor of Finance from College of Business at MTU. Today, we are going to have three speakers. Timothy Pletcher, the Executive Director from Michigan Health Information Network, Paul Stinson, the Chief Growth Officer from SunQuest Information Systems, and Thomas Verhagen, the Senior Associate from University of Cambridge Institute for Sustainability Leadership, Center for Sustainable Finance. So each of you will have 5 minutes for a brief self-introduction and your presentation. After that, it will be a panel discussion among speakers. So Tim, would you want to go ahead and start your presentation?
I sure will. So can I just get a thumbs up to confirm that you can see the slides all right? Great. Well, hey, I'm Tim Pletcher. Thank you so much for having me. I'm the founding executive director for something called the Michigan Health Information Network. And many of you may not be familiar with healthcare, but basically interoperability is a really big theme in healthcare and getting patients access to their records. And the US healthcare system in particular is highly fragmented. People can go wherever they want. There isn't even one number to match everybody. So it's a pretty chaotic experience. And so sharing information is really important to folks' health. So the Michigan Health Information Network was started as a nonprofit right here in Michigan, and it's designed to help hospitals and doctors and patients and health plans and even the state and federal government be able to swap information so that we can take really good care of people. We've been pretty successful in Michigan where we have dots all over the map. So all the hospitals participate, all of the long-term care facilities, many thousands of doctors, many thousands really of pharmacies. So a lot of the important information can be shared. Now, one of the problems is that people don't like to share information. You'd think that they would, but there's actually competitive concerns about sharing information. And so we've had to work in Michigan on something called the use case factory. We've had to build this sort of machine or this institution to be able to encourage people to share information. And the way that works is we work with folks who pay for things to provide financial incentives to motivate people to share information. And then we work with policymakers to create sticks or what are called policy levers to encourage people to share information. And the reason this is important, this process, is because when people do share information, a lot of times information is really not usable. It's very low quality. By attaching policy levers and incentives, we actually improve the quality of what we get out. And so those folks with the sticks and carrots actually provide those incentives to hospitals and doctors. Doctors share the data. Our organization runs what's called conformance reports. So we judge the quality of the information, the integrity, the usability of the information. We take those reports back and we send them to the policymakers or to the health plans. And it's kind of like people send a report card home to mom and dad. Mom and dad decide if they're going to give the allowance or not based on the quality of those reports. We just want everybody to get an A. So we want everybody to send good information. Now, let me give you an example of these little squares. Red is bad, green is good. Are hospitals sending data before they get their so-called allowance? Okay, and you can see there's a lot of red. Once the allowance period comes up or the deadline, lo and behold, everybody cleans up their process. Now, this is not a technology issue. This is a management issue. The chief financial officer calls the chief information officer and says, yeah, I really don't care. That's a lot of money. Go make our IT system do this and produce good data. And a lot of times they have to change a work process to be able to generate good data. And it makes a huge difference for those using it. Now, this has led to a lot of success, both in Michigan, but it's really positioned us to start and work across the country, out of Michigan, and even begin to sort of dig our big toe into sort of international activities. And so we started another company about 4 or 5 years ago called Velatura Public Benefit Corporation, and it's gone and works across 8 or 9 different states now. And then we also set up another company called nonprofit research institute called the Interoperability Institute. And it does all kinds of things. It actually puts through about 110, 115 apprentices every year in the health IT space. But it also works with academic institutions, standards organizations, tech incubators, and even a few of the sort of private think tank labs or government folks. And so this has really helped us be very successful as we go along. And my job essentially is to run all that. So I'm particularly interested in models from other industries because healthcare tends to lag behind other organizations. With that, Shin, I will turn it back over to you.
Thank you so much, Tim.
Good morning, everybody. I'm Paul Stinson. You may want to hit your volume there. And I want to talk a little bit today about health information technology and what's happened over the last probably 30 years. And as much as I hate saying that, I've been involved with it for about 35 years. So I've seen a lot of the transition happen. But what I want to really communicate today is really what health informatics or health information technology looked like, what it's accomplished, and I think what the future really revolves around, and give that capability, that little bit of passion as you guys go off into the working world and begin developing new applications. So let's go to the next screen. Health information or health informatics started at a really rapid pace back around 2004 when President Bush, during a presentation, really kind of focused everyone on putting an electronic medical record in every doctor's office in every hospital. And a lot of that legislation and that push formed things like the High-Tech Act, which was in the mid-2000s, the Affordable Care Act, which you're all very familiar with, which really is called Obamacare. But there was a lot of legislative push to get technology involved in healthcare to help reduce costs. And President Bush, in that State of the Union, really talked about the cost of errors in healthcare and the reduction of medical errors and the improvements in healthcare and improvements in costs that could afford. So about that same time, we were spending approximately $1.6 trillion on healthcare in the United States. Since then, in basically the last 20 years, that's increased to about $3.8 trillion a year, and approximately somewhere between 5 and 10% increase in spending every year. And this is something, even with the technology, that we haven't been able to significantly slow down that cost increase. Now, a lot of the things I'm going to talk about today are generalizations, and there are arguments all around the healthcare industry about ways to help reduce these costs. So a lot of the stuff I'm going to talk about, again, we could go really deep on it, but in 5 minutes, I just want to hit the highlights. But since 2004, health informatics has really provided an electronic medical record into almost all physicians' offices and hospitals. We've developed health information networks, one like what Tim just talked about in Michigan, but they're all over the country. So a lot of the technology has helped in sharing patient data and reducing the administrative burden of these record keeping and the transportability of data from facility or provider to provider. We've also improved the billing and reimbursement process through the utilization of electronic transactions, and that's really helped reduce a lot of the back office costs of getting hospitals and doctors paid for their services. We've adopted a lot of electronic transactions to support things like e-prescribing, billing remittance, and pre-authorizations. So that has absolutely helped on the back end to reduce administrative costs. We ensured portability and patient access to records through some legislation, but also the technology, and most of you have logged into your own patient portal to see results from the lab or results and notes from your physician visits. We have also established intrasystem integration through what they call Health Level 7 or HL7, and that allows information systems to talk to each other. So there's been a ton of work in the background to really help administratively reduce costs in healthcare. One of the problems, though, is that 90% of that 3.8 trillion is for taking care of people that have chronic and mental health conditions. And so while technology has done a great job administratively working in the background, making things simpler and easier and saving costs, it really hasn't driven down the costs on the clinical side of treating some of these chronic diseases. And what I want to really talk about is where in the future we can go with technology to make people healthier. And I think as we move into what I would call the next generation, the third generation of technology, we really need to focus on the reduction and improvement in chronic disease care throughout the United States. So what are these chronic conditions? Chronic kidney disease, COPD, which is a pulmonary disease generally brought on by smoking. You have asthma, diabetes, CHF, coronary artery disease, regular heart disease, and hypertension. These are the big ones that generate a ton of expense for the healthcare systems. Now, what I don't have listed here is cancer, which is from a curability standpoint, it's a difficult one to go attack, but it is still expensive and costly to the public. Another thing that really drives costs in healthcare is, from an orthopedic standpoint, the replacement of knees, hips, and spines, and typically driven by obesity for the most part, but there's also some chronic conditions genetically that are produced there as well. But these are areas that I think health information technology can focus on because there's opportunity for cost savings. And so the key is, can health information technology improve and reduce the care and expense of these chronic conditions? So if we take a look at it, high body mass index, which is typically obesity, costs about $240 billion a year in the healthcare system. Blood pressure, hypertension, high blood pressure, about 200 billion. Fasting plasma glucose, which everyone knows of as diabetes, is about another 200 billion. Dietary risk from poor diet, about 150 billion, and then smoking about 130 billion. And these are areas that we absolutely can take advantage of. And when I have the title there, modifiable health risks, there are things that people can do to reduce these expense. And the question is, how can we leverage technology to help reduce some of those costs? Some of the technologies that we should be looking at and evaluating, some of the technologies as you graduate from tech as an engineer or a computer science major, or even in business, things that you could get involved in to really help from a societal change standpoint, help reduce some of these costs. Predictive analysis from artificial intelligence can produce a lot of capability in analyzing the data that we get out of electronic medical records. Augmented reality or virtual reality can provide behavior change through education and training. We just saw, I think it was last week, that they completed the gap of the human genome mapping. And that's really going to help us understand from a family history standpoint how people can look at their genetic makeup and create care plans and things that will help prevent chronic conditions in the future. Wearables. There are a ton of wearables on the market today. What's unusual, I have a son that's a professional baseball player, and they utilize wearables 24 hours a day, and they manage the behavior and health of their players through these wearable devices. Data security, blockchain technology to help secure data to ensure that it's not available on the internet, but allow people to have access through technology. And then, of course, you got 5G and Internet of Things that can help in home health and socialization of potentially older folks that need that access to prevent some of these chronic conditions. So as we go through time, I really think there's a huge opportunity for improvements in technology that can go after some of these expensive conditions and make significant changes in healthcare. So thank you very much for your time. So I'm going to turn it back over to you.
Thanks, Paul. Next, let's welcome Thomas.
Thank you, Jin. So hi, everybody. I'm just going to share my screen just to make sure I got the right presentation right here. Here we go. So I'm going to share a really brief presentation. It's going to be 5 minutes. I was asked by Jeff and Amanda and Jin and the Dean to share a little bit about my work. I'm not a computer scientist, so I'm going to flag that up front. I'm a former banker with a business degree, and I specialized later in business model innovation and in sustainability and in sustainable finance. So that's me. Anyways, a topic which I would like to cover with you all today is an emergent space for people who sit in information systems, and that is information systems and sustainable finance. So information systems for sustainable finance. And I think that it's an unmet need, and that's why I wanted to share it with some of the like younger people that are attending this here today. So what we'll cover really briefly is the business rationale. It's not going to be about computing because I'm simply unable to do that. Just want to be straight about that. What I will discuss is climate is transforming the financial sector. Whatever the news is saying and partisan positions, doesn't matter. Finance is changing because of climate. Financial regulators are driving much of that change, as well as increased risk awareness within the financial sector. There's a lack of reliable information. Greenwashing is rife. Market players cry out for data. There's a crucial role for information technology here. And I wonder whether there might be similarities with health system information technologies. And that's something that I would like to unpack a little bit, if I may, later with Paul and with Tim, because I think there might be a lot to learn there. So a little bit about me. As I said, former commercial banker. I'm a senior associate at the Cambridge University Institute for Sustainability Leadership. This is King's College with a bunch of puns. To the left, you see Clare College. That's non-remunerated. I have a company as well. It's called WeSG, and we provide advisory services as well as training in sustainable finance, growing market. So the first point, you might have seen yesterday's report of the United Nations, the IPCC. Climate change is an existential threat. This is a heading from Reuters. It's now or never. Only severe emission cuts will avoid climate extremes. Currently, the world is on course for so-called hothouse planet, which has all kinds of potentially nasty repercussions. And with a limited cost, it would be possible to counter that if only new technologies and new consumption patterns were to be adopted. Now, that might be a relevant thing from an environmentalist perspective, but also financial regulators are stepping up. And whether it's the Bank of Japan, the Bank of England, the Fed, the SEC recently, People's Bank of China, or the MAS of Singapore, regulators all over the world in the main financial centers and the main economies of the world are tightening their management and their oversight for specifically climate risks, but also biodiversity risks. And they do this to two things. One, through prudential interventions. And the other thing that regulators and policymakers are doing is making it mandatory to report on the risk exposures that financial institutions and financial products have. And so how much are we talking about when we say, well, the economy need to change according to the IPCC, the regulators are stepping up. So what is it we're talking about? So I borrowed this from the Visual Capitalist website. This is all the capital in the world. There's a little bit more, but this is yeah, it's about it. And if we look at what it entails, now this is all the gold in the world. To the left, cryptocurrencies, 2020 figures. US budget deficit of 2020. All the coins and banknotes in the world. The money supply. Here at the bottom, you see the stock markets. Fortune 500 here at the left. There's some global stock markets. The main ones are all of them. And this is all the debt in the world to the right. Now, when we're talking about these measures of the regulators, we're talking about this piece. So you can see that by far most of the capital in the world is within scope, and more still, according to research from the asset management industry, Global Sustainable Investment Alliance. This is not some niche organization, but these are some of the biggest asset managers in the world combined. About 1/3, a little over 1/3 of all investable assets in the world. So that's the stock exchange stuff here at the bottom, and all the fund products, etc., are currently labeled ESG. Now, there's a problem there because also there's a lot of greenwashing that's rife. Morningstar, a big player, cut 1,200 funds from its sustainability list because the language is too ambiguous, information is unreliable, the data often is unreliable as well, and regulators are stepping up to squeeze out that greenwashing. Now, industry is lamenting that there's a lack of data underlying these issues. So there's pressure on the one hand to disclose and to change the structure of the financing of the underlying economy, energy systems, what we consume, food systems, the built environment, transportation, you mentioned it. And on the other hand, there's no real insight in what is sustainable and what is financed in a sustainable way. Now, these are some quotes from the World Economic Forum and from the UN. But if you speak to practitioners in the financial sector, this is the big ask. So this brings me to the role of information systems, because people who do not sit in computing or who do not sit in the world of information systems won't be able to solve this on their own. So there will be a need, probably, I think, but I'd love to be challenged, for non-practitioners in information systems and information system experts and professionals to collaborate across knowledge domains. You can't just sit in your own silo. And there's a need to unlock data in order to be able to identify where the risks from sustainability sit, biodiversity loss, and climate change as well, physical risks, also transition risks, the risk that assets become worth much less at a certain point. If you're interested, I can talk a little bit more about that. There's a need to connect data. So I heard Tim speak about interoperability and sharing of data, etc. There's some initiatives out there. There's the open data movement, but that happens way too little. Everything sits in silos and is frozen up. And then the overarching objective, of course, is to enable information sharing within the financial system and between real economy players in all kinds of sectors and the financial system, and between the regulators in the financial system. So all of that needs to be done in a secure way, obviously, and also this is a role of professionals in information systems. Now, I've been thinking about what might be, and this is all not there at the moment. There's a dart of data, there's a bit of a wild west in terms of information that's being provided, a lot of greenwashing, and information systems are not being applied, or they're not being well applied. Now, I think that healthcare systems are earlier in the curve, notwithstanding that Tim indicated that he's also here to learn. I think that sustainable finance can learn from professionals in the health information systems business, because the data is about a social phenomena. It's complex phenomena, and the data and the information requirements evolve over time. It can be context specific. The stakes are high. We're talking about existential risk here, and in health information, you talk about life and death situations. There's large money flows. We saw earlier how much capital is involved. And the information is not always binary, contrary to, for example, financial or bookkeeping data. Now, with that, I want to draw to a close. But I want to thank you for your attention, and I look forward to the conversation with Paul and with Tim. Thank you.
Thank you so much. Thank you, Tim, Paul, and Thomas. Now here comes to the time for panel discussion. If you have any comments, questions, echoes, please go ahead and talk or discuss the speakers.
I'll go. Thomas, I'm really interested to see your list of comparison of the finance industry to healthcare. I think you nailed what are the key constraints that we operate on a regular basis. I also was unfamiliar with the visual capitalist space, and so I think that's a really good graphic. But you know, taking a sneak peek, that's actually a really good resource for folks who are maybe listening to this if they're unfamiliar with it. So a very awesome way to represent information. One of my questions for Thomas was, are there dominant vendors in the finance industry? Are there a handful of vendors who control it? Because in healthcare, sort of like in manufacturing, where SAP sort of dominated the manufacturing ERP space, we're actually seeing a handful of vendors dominate the electronic medical record space in the US. And so I just wondered if in the finance industry, there are a handful of players who have a little bit of a hegemony over everybody else.
They're trying to, Tim, but I believe that they're not there yet. And what we see is that mainly it's some legacy players, so MSCI, Refinitiv, Fitch, maybe, you know, there's some of these big rating agencies and data providers for the financial sector, Bloomberg maybe as well, that try to grasp this market. The issue with their approach is that they all want to own the data on a proprietary basis. Hence my nod to, for example, the open data movement, which tries to have more of that interoperability and data connection instead of data ownership that's out there. I know of one initiative that tries to achieve that for climate data. It's part of the World Economic Forum constellation. It's called Icebreaker 1. But I think there's going to be a need for way more initiatives out there. And hence, I hope to inspire these young people that all study with Xin and with Dean Johnson and with Jeff at MTU.
I have a question for both Thomas and Tim, and it's a lot about the comparisons between fintech and healthcare. So for 30 years, I have sat in meetings where people go, the financial industry is so much further ahead of healthcare when it comes to technology. And one of the things that fintech has is the ability to have these connectors. So I can go anywhere in the world and use my ATM card, and it knows where to pull the money from my checking account. I can go into, let's say, Mint, and I can put in all of my bank information, and in one application, it connects and provides all of my data. There are connectors in the background that pull and provide authentication. But Tim, being in that world, maybe you could highlight the fact that we're not quite there yet. You have all of those hospitals, all of those doctors' offices, and it is not very easy to connect and have a patient go in and have a consolidated medical record that pulls data from every place they've been in their life. Maybe you could talk about how that's changing or what you see in the future in that area, because fintech has accomplished it, but we haven't yet in healthcare.
So let me give you just a quick example, and I'm going to tell you this is not a technology problem, okay? And the reason it's not a technology problem is if I look at the banking industry for hundreds of years, we have had the paperwork, the process to share money or to insure something traveling in a ship across the ocean to someplace else for what value. Okay. So in the when we get healthcare compared to the finance industry, you've had these sort of international processes to sort of move wealth and money for a really, really long time. In healthcare, it's really been a localized, literally a physician putting their hands on a person, right? I mean, going to a stethoscope was a big move for healthcare. So we have not had the business process or the paperwork. I mean, things like HIPAA, transactions, we haven't had that defined for us. And we haven't had the history. And frankly, it costs a hospital money to lose patients. Okay. So when somebody goes to the emergency department or they get readmitted, the current model doesn't really reward them for not having that patient come back again and again and again. And the idea of sending your patients all over the world didn't make sense. Sending your patients all over the state didn't make sense. So the business process, I think, has lacked. The second piece is, for however you want to say it, there's more money, or at least there used to be more money in the finance industry. And so they had a lot of failed tech projects in finance. Okay, they shut them down and there's no ROI, but they spin them up. And they were leading edge for a lot of the new technology that we haven't used, a lot of the AI kinds of things. Why? Because it was worth it to experiment, because there's so much money involved. Healthcare is slowly catching up, but we've been on paper up until the High-Tech Act that you mentioned, Paul. And so you will see the healthcare industry go like astronomy, high particle physics, where we're drowning in information for a while because we finally got electronic systems and only AI and other things will sort it out. But we still have some business model conflicts where specialists don't want to share their data. We had to pass a law in the United States, called the information blocking rule, to stop hospitals from holding their information and everybody else. So I think we're catching up, but I think you got to remember that there's a long history of moving, not necessarily electronically, but finances around.
And just let me add to that, Tim, one of the things that I think hurts us a little bit is the competition between hospitals and the Chinese wall between a firewall between the payers and the providers. And so a lot of folks don't want that data out there because hospitals negotiate their reimbursements with the payers, and they hold a lot of cards, a lot of data about their care programs and their costs silent in those negotiations. And so when it comes time to, let's say, I want to compare, I need an MRI and I want to compare the cost between 3 providers, a lot of that information isn't readily available because it's hidden behind these contract negotiations between payers. And I think part of that has to break down. I'd be interested in your thought there too.
Walmart is going in. Walmart, CVS, Walgreens are all going into the care business. They're hanging their price list outside. $40 you can go to get a visit. I believe you'll see some real competition in the future, totally enabled by people being able to pay on their phone and basically get their info on their phone. So I think you're going to see a lot of innovation on that front, and it'll be very, very competitive because it'll just drive those costs down. I think I saw a stat, over half the US population has been in a Walmart in the last month or so. So I mean, that change is coming to our system but it's come through kind of like we did for monopolies, specific legislation to say you can't hoard the information, you can't stack your own silo up. So I'd love to hear Thomas's sort of interpretation, because you know, the world does not all use the same healthcare model.
No, that's true, Tim. That's true. So in the preparation, and Paul and I had a discussion about this a little bit as well, because it varies from country to country how healthcare is financed. Like I'm in the Netherlands right now. Everybody pays health insurance. I pay like 130 euros a month. And then you get like mostly anything is covered. You have some first loss on risk, like 300-400 euros, and that's it. And then the insurance companies pay out the care providers. But of course, I lived in the UK as well, and there it's the NHS, National Health System, which is basically directly funded to tax payments. And I think the incentives vary from model to model. Thinking in terms of information systems and having the bulk and the clouds to experiment and basically the capital to fail with experiments similar to like some of the big financial institutions had, just as Tim just indicated. I think an NHS model might be more applicable because they are simply have the volume and the capacity to absorb those experiments, kind of like DARPA in the US, for example, also the ability to absorb some quote unquote brilliant failures. Great idea, didn't work out, but we learned. I think that there's something there. The other thing that struck me in your discussion, it seems to be that traditionally banks and investors very much have a stock and flow mindset. So you have a stock of something, including all the data on that stock, and then you have a flow out of that something, including the data on the flow, and whether the flow is a shipment or the stock is a piece of agricultural land. You know, the underlying rationale is similar, and I kind of sense that within healthcare and healthcare information systems, that type of thinking about stocks of data and flows of data, stocks of preventative measures maybe, or individuals and flows that come out of that might be a bit earlier in its thinking. And I would welcome some thoughts from Tim or from Paul on that. Like you mentioned big data, you mentioned different types of data analytics. That's approaching a stock of data and a stock of patients, if I may use that word, there's no disrespect meant, through that mindset, instead of this very localized, individualized record keeping and no communication between it. So there's some questions as well. So I don't want to hog the air, but I was really curious about that thinking.
We do see quite a lot of, you know, system dynamics kind of models where we have this idea of stocks and flows. They're a lot around capacity planning for emergency departments because they're always so busy.
Yeah.
And we started to see a fair amount around transitions of care, recognizing that there's sort of a medical neighborhood. It might not be multi-state, but it is some concept of a medical neighborhood, and who's in it, and what do you need to do to sort of get a complete 360-degree treatment process, care pathway around an individual. And so there is a fair amount of that, and some of it quite formal. Hospitals generally have an awful lot of stocks and flows kinds of mindset, but it's traditional logistics, capacity planning kinds of things that
Yeah. So it sits less in curative care. And the thing I would be super interested in is to what extent that type of thinking is being applied to preventative care, like, you know, making sure that people don't get into a hospital in the first place, and some of the stuff that Paul was talking about, I think, earlier.
We could go on here a long time, but there's something called the chronic care model that was sort of developed that sort of looks at that holistically. But the problem is everybody owns a piece of that holistic view.
Yeah.
And there isn't anybody responsible. And so it's kind of a tragedy of the commons, where space in the middle that nobody owns. And so nobody steps up to take care of it. And that's sort of a tremendous failing with the sort of fragmentation and the approach we have in the US, is that while other parts get really highly optimized, that holistic piece, you have to sort of take conscious steps and discipline to figure out how to prevent that tragedy of the commons from occurring, because people will fall through the cracks.
And that's something similar with sustainable finance, the data needed for sustainable finance as well, I think, to be honest.
Yeah,
how do you incentivize people to provide data about deforestation or about emissions or etc.? Sorry, Paul was stepping in. I'm just a bridge, that's all.
Well, one of the things I was just going to add is the cost or the expense is really played to the employer in the United States. And they're the ones that are paying a lot of the expense of these chronic conditions. And so they're also the one who has to be motivated. So it's got to go past the patient to being motivated about reducing some of these costs, but it also has to be upon the employers too, and getting them working with the care systems and the providers. And it's happening in some areas, but that's also another huge boulder that has to be moved in this whole process if we're going to reduce costs.
Yeah, I see we have some questions. I don't want to ignore our company.
We're bolting off.
Yeah,
bolting off.
Zen is getting them.
Yeah, I'll go ahead if that's all right.
Yeah.
Yes.
So I have two questions. One's maybe more of a comment. I was wondering if Tim could go ahead and talk about, and I apologize, I was a little bit late coming from another meeting, but since Paul mentioned the interoperability aspect in the sharing, if you could mention TEFCA and what are some of the different types of possibilities associated with that?
Sure. I think so. The Trusted Exchange Framework and Common Agreement, which we pronounce TEFCA, is part of the 21st Century Cures Act legislation that sort of came out. And basically, TEFCA, as we abbreviate it, has got two parts. It's got the Trusted Exchange Framework, which is sort of a generalized national model for trusting peer entities. So there's this idea that there's a regional coordinating entity, think of it as an umbrella, over the top a bunch of qualified health information networks. We call them MTUs. And they all expect all of their participants, those are the organizations that connect to each of these qualified health information networks, to sign the same legal agreement, which we call the common agreement. And when everybody signs this common agreement, there's a set of expectations that they'll all be kind of governed and operate by the same rules of the road. Couple things, TEFCA is just slowly taking shape. Also, it's completely voluntary. So until Centers for Medicaid and Medicare Services makes it a mandatory requirement to participate, it could be a long term before there's sort of a ubiquitous solution there. And it's highly oriented around last generation technology. So if you're familiar with sort of SOAP, it versus RESTful APIs, it makes a big difference in terms of it's starting off with models that we know, which are things like that evolved out of the nationwide health information network. So there's organizations like Care Equality, which is largely driven by sort of the EPIC community, Commonwealth, which is largely driven by the non-EPIC community, and then there's eHealth Exchange, which is really the first and probably one of the most operational, which is got a lot of the early adopters and also the government itself. And so those three entities are largely believed to be, sort of the shoe-ins for TEFCA. But ultimately, we may see a lot of other folks sign up to become Cubans. Did I cover it, Guy, or did you want?
Yeah, no, that's good. That's great. Yeah, it's a good segue into it. So I just sent a link of one of the blockchain companies that I've been kind of targeting to in terms of looking at different types of patient data and giving them the option to share it. And so as you start seeing things with Big Pharma and other ones, they're looking at different types of ways to incentivize patients to be able to either anonymously or not anonymously share their data for different types of Bitcoins and things like that can be used for different types of services. So thank you, Tim.
You're welcome.
Hi, I'm JJ here. So I have a question. So I feel like, but there's not really incentives. Like Paul said, there's not a lot of incentives for the hospitals to really, you know, provide the information. But I also feel like, you know, in the healthcare business, you know, there are a lot of complications. If you know you search the PAC system, you will see the information will document differently in different hospitals. It's, you know, not very standardized. So, but I having hard time to believe you will provide enough incentives to the physicians to standardize that. So how would you envision, you know, that would be what will be the way to go? But the second part is more my comment. I feel like, you know, not trying to brush you guys, but I feel like when you guys talk about it, you know, you guys are more talking about that from the business standpoint. You know, there's a less human element in that healthcare, you know, informatics area. You know, so I mean, I think it's different from the banking industry. You know, and the banking industry is a horrible example from many aspects. So the fear from others is certainly that if the healthcare become just a replication of the financial sector, that actually will be a disaster. That's just my comment.
Well, I've got a couple thoughts on that. One, when I first started MiHIN over a decade ago, we got everybody in the room, all the players, the hospitals as well, and we said we need to let everybody know when somebody goes in and out of the hospital or in and out of the emergency room. And they did a little multi-voting. We stuck these little stickers on the wall. It was a great meeting. Everybody was very excited when we left. I was excited. And then when I said, okay, hey, I got the technology ready to go, everybody send me your data, all the hospitals said, no, we're not going to do that. And I said, but we multi-voted, and it was a great meeting. And they said, yeah, but we're concerned about competitive kinds of stuff. And then I went to all the payers, the health plans, and they said, wow, that was a great meeting. Really enjoyed that. Want you to know we're not going to give you any money. I said, what? We had this big meeting. We all were excited. And make a long story short, I ended up going to the health plans and saying, well, I'll tell you what, why don't you use your market power and your incentives that you're already paying, take 15% of those incentives you already pay to the hospitals and directly tie them to participating in this admit, discharge, and transfer notification use case. And they did. And all the hospitals were pissed off. They screamed and yelled, but as the deadline got closer, they all sent the data. Okay. And then the next year, we raised the bar like a sales quota and said, yeah, not just send crappy data, but you need to send it, conform it to a better quality, more usable level. We're now at 47 different use cases that we've done that way, and it works. And not only did it work, it got everybody to send the data in 9 months, not 9 years. Okay. That very first time. And we've done this now in other states where they've tied some kind of policy lever or financial incentive to people doing the right thing. They know it's the right thing, it's just not a priority. And once you get that sort of flywheel going, it just makes sense because it actually is in our mission to take care of people. But you have to build some kind of, I'll use Thomas's word, sustainable process that you're not constantly writing them checks. It's wired into the rest of the system. So we don't write them the checks. We just do the report cards. Somebody else, the government, the payers, et cetera. Basically, it's a simple management lesson. You pay people or you punish people and you get the right result for doing the right thing. The trick is to pick value creating activities. So you're not just doing senseless regulation or senseless motivation. And that's hard. But that mechanism produces results. And I think that Thomas will see the same kinds of sustainable multi-party actions driving the right things to happen. It's people aren't just going to do things because it's the right thing to do. That we've got years of evidence of people standing around talking about the right thing to do. There needs to be some carrots and some sticks associated with it.
Tim, I couldn't agree with you more. And a perfect example is, as you remember, 5 years ago, a doctor would not take an email from a patient because they weren't getting a reimbursement for it. The payers are now paying some for telehealth, some for responding to emails. And so that incentive for them to take emails, to respond to emails and utilize a more technology-friendly care interaction on certain things is there. And part of that is driven by the market. And if you were to compare some of the changes, and I don't want to get into a very political conversation, but at the NHS in the UK, they generate a budget through their administrative legislative process for the NHS, and that's how much money they get. And so care is distributed based on that budget. In the United States, it's a little different. I would call it more market drivers, right? As technology and things change. And I think that helps provide better care to the patients because those financial incentives may be there and not legislated from a care perspective through a government agency. So again, we could probably argue about that kind of stuff for hours, but in response to JJ, there's got to be an incentive financially. And when those financial incentives are there, you're going to get better care out of the physicians.
Well, but Paul, I mean, Tim, I'm not trying to argue with you. I think what I'm trying to say is that you guys may see some drug effects. Some certain drugs will initially be useful, but eventually will break down. So I think hospitals are incredibly smart. They hire a lot of people. Eventually you will get back to you guys. So that's my comment. Now, the other thing is that I'm not trying to get into political discussions, but I think the marketing force will further driving people living in rural areas or dispensary area out of the healthcare. The access has been a huge issue when for people living UP. We often drive like 300, 400 miles to get the quality access. So I'm not, a true believer of the marketing force. So, I mean, just my comment, it's very sad to see, if you guys are leaders of the implementing these policies, but you guys talking about was a purely market-driven approach without taking the human element into
well, think of it this way, JJ, and that is, one, I got my doctorate in health administration just to understand how CEOs of hospitals think. Okay, that was my sole major motivation for understanding that. But the second piece is, there's a whole movement in the United States called direct primary care. It's worth Googling. Direct primary care does not take any insurance, doesn't take any government money. It basically just says you write a check to your doctor and get unlimited care. All right, and it's different from concierge because it's affordable. It's in that $40 a month to $80 a month, pretty much what many people pay for their copay. All right. And so the system has gotten kind of out of whack, but here's the thing. If the big capitalized infrastructures like payers and health systems aren't forced to have a certain liquidity of information, innovative solutions like Walmart and direct primary care can't provide those kinds of services. And so, either you go to nationalized medicine or you go to the kind of innovative things where AI and blockchain and this other stuff can sort of provide solutions, or you're stuck in the middle, which is a really unhealthy place to be. And so people, we think, have got to get, free up the people to be able to get access to their own information, which is now happened under TEFCA and 21st Century Cures Act. So there's private right of access to your own data. You don't want your data for yourself. You actually want to give it to either some AI or some human being who's a physician to take good care of you. But giving people that control is the way that we've structured the sort of humanness of the system. And what we're seeing is it's all about doctors and patients. It's not about the EHR. It's not about these big monolithic systems. But if you get everything locked into a big process and locked in to these other systems, then people and doctors are just going to be cogs in the system. And I think what we're really trying to enable is whatever the best model is to sort of break free and solve itself.
Well, I'm not.
Can I chip in, gentlemen, because I got something to share, JJ. So I think what I sense in your question is a concern a concern about the use of information flows, because it's a powerful technology. And as any powerful technology, it is, I always get these two wrong. I think it's immoral and not amoral. You can use it for good, you can use it for bad. And I think that the financial sector has shown some examples in which data use or use of models, which is also a form of technology, went off the rails in a horrific way. I think that boils down to purpose and staying honest to a purpose, and that's a very rising theme within at least commercial organizations, businesses around the world. And I think that's also a thing that's maybe the red thread in this session, because why would we talk about sustainable finance and the information systems needed for sustainable finance and healthcare information systems in the same breath? Because I think underlying that is a sense that there is a need for purpose. And the purpose can be served by technologies that can make things more efficient. And that's the risk with efficiency, of course, is where do the benefits accrue? Who's going to get the money if we have savings? That's a political question. You know, American healthcare is twice as expensive as Dutch healthcare per capita. $10,000 versus $5,000 per citizen a year, right? So, and that accrues to businesses, mostly in the US. But maybe also there's higher quality. I don't know. You know, that's a political debate. But there's a division of the efficiencies. There's also the ability to create new flows of value, and I think that's what Tim is pointing at. You know, if you want to do things in a new way, it doesn't really help to be stuck in old infrastructure or in old fossils, so to say. And to that point, and this is my second point I want to make. So it's purpose. It's different forms of value, and there's a political economy around who can put their hand on that value. Is it individual human beings? Is it individual institutions? Is it the providers of capital? You know, that's a political economy question, not an information systems question. And each society or each context will provide a different answer to that. The third point is governments have a role to play in providing markets. If you don't have a government underpinning a market, it will not shape by itself. Yeah, maybe it will shape in a way that you see in Somalia. You know, there's a market there, but no government. So what you see in the financial sector in Europe, for example, there's been a major regulation on information sharing within the financial sector called PSD2, Payment Service Directive 2, in which the banks basically were broken open by the regulator to allow individual account holders the right for third parties to access the payments data of their account. And banks were hogging that for decades. Now, they found all ways around that, but there's going to be a new round. PSD3 is coming now. So it's like a bit of a battering ram to unlock that data. But you see the role of government there. And the purpose that is being served is unlocking new flows of values, like Tim just indicated. Okay, sorry. And then I'm going to stop, but it's these 3 points that I wanted to make, which I think both sustainable finance and information systems and healthcare information systems share.
Thank you so much. Thank you so much, Thomas, for the discussion. I have one last question for the MTU students, because I want to diversify the discussion and save some questions for the students. That is, what do you think is the best resource for people, especially students at MTU, who want to get hands dirty or dive into deeper in sustainable finance and health IT system? What's your practical advice you would like to provide to someone just starting out?
I can go first if you want. Go to Google the Office of the National Coordinator for Health IT and start looking at their websites. That will start guiding you everywhere. And then the second piece is Google FHIR for sort of the latest technology. And those two things will take you down many different paths. But just to get started, those are the two things I'd say are the fastest. Paul, you got an improvement on that?
No, I think you hit the nail on the head. And certainly looking at some of the major players, just hitting some websites, go to Epic and look at some of the technologies and solutions that they provide, Cerner, for example, or Eclipsys. Those are all companies in the marketplace that have solutions and opportunities and potentially job opportunities as well. So I would look at some of the big providers, Blue Cross Blue Shield, Optum, Universal, and look at some of those guys as well to see what some of their technologies are. That's where I would also add to that.
Yeah, so I don't think that the information systems for sustainable finance are as mature as those for healthcare yet. If students are interested in this domain, I think the places to look at are either start building it yourself, or join a team that builds I think solutions like this. So then you very early get into the space of tech accelerators, Y Combinator, Techstars, those type of programs. The venture capital world as well. So there's that element. Maybe looking for a co-founder or joining a small startup team. The alternative would be to join any of the bigger providers that Tim alluded to. So you could look at Refinitiv, you could look at MSCI, Fitch, Bloomberg, CDP, Carbon Disclosure Project, Sustainalytics. So there's a whole bunch of providers out there. But I think that's the two main routes that I can see at the moment.
Great. Thanks much for the suggestions. And one more question is about what's your predictions in the areas for the sustainable finance and health IT system? Because we know that these two areas are in the high-speed train. So every year or every month, if we look back, it's a new world, it's a new industry in these two areas. So what's your prediction? What do you predict will happen in the next 5 or 10 years in health IT and sustainable finance?
Well, I'll go ahead and go first. I really think the future is in areas that Tim is quite familiar with. I think he dropped off, but the ability of mining healthcare data, being able to concentrate the data to a certain patient does not exist today. If you're a patient, you probably exist as a patient in multiple different systems out there, and they don't talk to each other. So a lot of the work that Tim is doing with pulling data together, providing transportability or portability for data, I think is where a lot of transactions are going to help. I think the creation of digital connectors, like what has happened in the Fintech area, is another area that will be successful. And as I talked about earlier, there's got to be technology to help reduce costs of chronic conditions. So in my opinion, those are some of the areas in the next 5 years that are going to accelerate.
I don't know if you can hear me. I am back. So am I back or not? Yeah, okay. So yeah, I think COVID showed an awful lot of telehealth and virtual care happening. And those happen to coincide with a lot of people getting access to data on their smartphones and things, and the patient private right of access. So what I think you're going to see is an awful lot more. Guy put in a blockchain link. I think you're going to see an awful lot more of people getting their information, not knowing that it's coming from multiple systems, putting it together, and being asked to give their information, whether it's to enroll in a clinical trial, whether it's to sort of de-identify their data and participate in something. So I think you're going to see an awful lot more of that. But I actually think you're going to see a financial change where increasingly high cost people are going to get more access to their money to do some flexible kinds of things. Not everyone is going to pursue this, but a lot of people will. Oncology patients will do this. New mothers will do this, where buckets of money, and the banks will show up and say, we want to hold that money for you. Sort of like folks who have a health savings account kinds of things. There's a fair amount of money now in the healthcare space that is sort of in the hands of the consumer, because consumers in the US are paying a lot more. And so I think you're going to see an intersection of the health IT space and the banking space, where individuals who do want to take responsibility are going to kind of manage their money and those expenses. And then that's going to be interesting when you go to see options from Walmart or CVS, et cetera. So those are mine.
So yeah, I don't have a crystal. It looks like I have a crystal ball, but I don't have a crystal ball, folks. So I'm gonna have to be really afraid about that. Thinking about your questions, I would carve it up in two parts. One is what might be functional domains of growth, right? What type of functions might need to will probably grow, and the other is what type of sectoral growth could we see? Are there going to be certain sectors in which these functions are going to be in more need than in others? And again, I'm looking at this from a business perspective. I'm not looking at this from a technology perspective. So I think some functions that will grow within information systems for sustainable finance, they would sit across connecting data sets, so unlocking and connecting data sets, existing data sets, and also getting the right incentives in place to do that. So much of the things that Paul and Tim have spoken about. Auditing and validating those data sets in a mostly automated way, triangulation, using sensor technology, that kind of technologies, and then the aggregation that Tim was speaking about, just having one interface to be able to access the plethora of data and information that might be needed, either by a corporate, by a financial institution, decision makers there, or private individuals. And that brings me to the sectoral areas of growth that I would expect. In terms of parties paying the bills for this development, if you are a solution provider or a startup or a big party providing this, there's going to be a lot of growth within the banking sector because they're awfully regulated, and most of the capital in the world is being provided by banks via the loan books, not via markets or equity or investments. Banks and the loan books are the biggest capital provider in the world, through leverage, and they are regulated and they have to comply and they have to provide the information. So that's a big growth market. And the second growth market I would see is defined benefit pension holders. There is, there's a lot of private people who are worried about developments around climate and biodiversity, especially of the younger generation. This is happening across the globe. And they want to be able to allocate their pensions in a way that's aligned with the stuff they worry about, the stuff they care about, and that within asset management or within the investment community will probably be a growth market.
Thank you so much, everyone. We are just on time. Thank you so much for your presentation and insights and suggestions to our students. And this is Computing MTU Showbase. I'm really looking forward to seeing you guys in other sessions.